Hello, my name is Joanna Saishan, and I'm recording this for pathophysiology. I will be discussing cystic fibrosis today. Here is the first page of my notes, second, the back page that I will be referencing throughout this video. So starting out, the definition of cystic fibrosis, or CF, it's an autosomal recessive disorder that involves exocrine glands in the epithelial linings of the respiratory, digestive, and reproductive tracts. The defective gene that's involved here is the CFTR gene, cystic fibrosis transmembrane regulator. Its dysfunction leads to excessive production of incredibly thick mucus that will cause obstruction in the lungs and in the pancreas. Classification of the disease. This disease can be classified in thousands of different ways with thousands of different defects in the CFTR gene in the process in which it is made. But there are 6 main classes. The most common of which is the class 2 maturation defect. It's seen in about 70 to 80% of people with CF. But just to give you a few more examples of certain defects that can occur, the class 1 defect is defective protein synthesis, class 3 is a gating defect, and class 5 is just reduced quantity of these CFTR channels. Etiology, or the cause of this disease, can involve mutations in the long arm of chromosome, or does involve mutations in the long arm of chromosome 7 that miscodes CFTR. CFTR functions in the body as a chloride channel in epithelial cell membranes, the result of which can lead to these membranes being impermeable to chloride. If there's a defective channel there, there's no channel there, these tissues are impermeable to chloride. As I said before, the most common mutation is the class 2 mutation defect or maturation defect. Also can be called the F508 defect, in which the CFTR is being created, but there's a misfold occurring somewhere along the maturation process. CFTR issues and defects, as well as chloride transport issues, are tissue specific. So, for example, sweat glands. When we sweat, we're secreting sodium chloride. Sodium chloride is coming out of our bodies, but it's usually being reabsorbed back in through the chloride channels. The chloride goes through the CFTR, and the sodium follows its concentration gradient. Without the CFTR channels present, there is nothing to bring that chloride back in and nothing to push the sodium chloride back in as well. This is why people with CF present with very high concentrations of sodium chloride in their sweat. In the airway lumen, we also have chloride secretion into the airway lumen, followed by sodium and water secretion that makes the mucus very liquidy. Not very liquidy, it just makes the mucus liquidy, more motile. It can move throughout the from the bronchi up. You can cough up some mucus a little bit easier than if the CFTR channels weren't there. When they're not there, there is no chloride secretion into the airway lumen, therefore no sodium, no water thinning out that mucus, leaving the mucus very thick, a very thick coating that can lead to obstructions in the airways. The syndrome, I would put this under obstructive bronchial syndrome. And as far as clinical manifestations go, there are a few different things. The respiratory manifestations are caused by that really thick viscid mucus formation, accumulation in the bronchi. Issues can begin as bronchiolitis or bronchitis, and as these reoccur, as these get worse, as the condition worsens, it'll lead to bronchiectasis. People with CF are very incredibly predisposed to infections, and pulmonary inflammation occurs very commonly. Other respiratory manifestations can include some wheezing and a cough with very thick mucus, difficult to pass. Pancreatic manifestations includes diarrhea or very oily stool, diarrhea, abdominal pain, and discomfort. Newborns may present with meconium ileus, which is an intestinal obstruction due to that very thick mucus. It's obstructing um, the intestines, and it may become fatal. Pancreatic involvement can vary very widely across CF patients, and there may be some exocrine pancreas insufficiencies and hyperglycemia that occur as well. The hyperglycemia usually occurs after 10 years of age and may develop into diabetes mellitus eventually. Diagnostic tests, as far as they go, early diagnosis and treatment is key in preventing or delaying many of the illnesses that can occur in newborns with CF. Generally, the diagnosis is based on the presence of the respiratory and digestive manifestations, as well as history of CF in siblings or a positive newborn screening test. A key diagnostic test, though, is the sweat test, in which the sweat is collected by pilocarpine iontophoresis. And it is analyzed chemically for its chloride content, because as I said before, there's a high concentration of sodium chloride in the sweat of people with cystic fibrosis. And this sweat test is the standard approach to diagnosing CF. Differential diagnosis, one of the key differential diagnoses that I saw was the primary ciliary dyskinesia. In PCD, there are also chronic respiratory infections that occur, but in primary ciliary dyskinesia, the issue is in the cilia themselves. They're not as motile; they can't move the mucus as easily, whereas in CF, the dysfunction is in the mucus itself. It's so thick that it isn't able to move thanks to the cilia. But in both, we have impaired mucosal clearance and chronic respiratory infections. And lastly, possible complications. Infections are huge here. The cystic fibrosis airway epithelial cells are a favorable environment for bacterial pathogens, especially Pseudomonas aeruginosa. And yeah, thank you for watching.